So this talk is aimed just to go through your first two cardiology case-based learning sessions as a bit of a roundup. And we'll start talking about the first case. You were presented with a case of a 56-year-old man with central chest pain. And in terms of the history of that presenting complaint, it was sudden onset at rest while he was in bed. It felt heavy, as if someone had sat on his chest. It radiated to both shoulders and was severe, with the patient rating at 8 to 9 out of 10 in severity. The pain lasted greater than an hour, or more specifically until the paramedics arrived and gave morphine. And associated with this pain, he felt clammy, sweaty, nauseous and short of breath. He is an ex-smoker with a 30-pack year smoking history, is a hypertensive on medical management from his GP, and drinks approximately 30 units of alcohol per week. In terms of past medical history, his paternal grandfather had a myocardial infarction, of which he died at age 58. His father also had a myocardial infarction at age 55 and went on to have a coronary artery bypass graft. His paternal aunt also had a myocardial infarction age 52. He works as a plumber and is normally independent. Lives with his wife, who has multiple sclerosis but is also independent. And he tells you he has 2 daughters, 1 son and 3 grandchildren. He takes amlodipine prescribed by his GP for treatment of hypertension. And in terms of his patient perspective, he tells you he knew it was his heart and he is scared that he will die. So at this point, we would already ask you to start thinking about clinical reasoning and what might be at the top of your differentials and what you think might be going on. Things that I was hoping that you might be able to pull out of this history, for starters, is that this is a very good history or a classical presentation of cardiac ischemic pain. This is also a chap who has a very strong family history, including first-degree relatives of significant ischemic heart disease less than the age of 60. The patient also has a significant smoking history and is a hypertensive, both of these being further risk factors for this being ischemic heart disease. The other important thing to note in this history is that the patient has both children and grandchildren, so already start thinking about potentially, given his family history, and if this is proved to be a myocardial infarction or ischemic heart disease, what the potential risks might be to his grandchildren and children of similar events happening. We'll talk a bit more about that as we go through the presentation. So in terms of the patient pathway, his wife calls an ambulance. Paramedics will perform some basic observations and a ECG. His observations are generally unremarkable, but this is his ECG. Now, really don't worry if you're still finding this pretty intimidating and difficult to interpret. We are just at the very start of your cardiology teaching, and really to get confident with ECGs, it takes a lot of practice and probably a lot of years. But for starters, it's really good just to get used to going through a nice logical approach to it, interpreting them. Breaking things down into modules always makes things less intimidating. So we always start by checking it's the correct ECG for the correct patient and the clinical context of that ECG, i.e. has the patient got convincing cardiac pain alongside it. Then look for P waves, and in ECGs there's often a fair amount of artifact, and again it can be difficult when you first start, but I'm convinced here that there is indeed a P wave before every QRS complex. It looks nice and regular, and because it's regular we can use the 300 rule to calculate the rate. And we can see that there are roughly about 3 big boxes between every R wave. So 300 divided by 3, we can say that this ECG is approximately 100 beats per minute. In terms of axis, our complexes are predominantly positive in leads 1, but predominantly negative in leads 2 and leads AVF. So this is a left axis deviation. We then look to see whether there is any ST elevation, so whether the ST segment in any leads is elevated above the baseline, which would be the TP segment. I can see ST elevation in probably V1, but definitely in V2, V3 and V4. Now, if this isn't totally clear to you, there's absolutely no shame whatsoever in going back and watching my teaching on interpreting ischemia on ECGs over and over again. This is not an easy subject, and it can take a while to get your head around being able to interpret these confidently. On this ECG, there is also T-wave inversion in leads 1 and leads AVL. In leads V1, V2 and V3, we can see that our first deflection in the QRS complex is a negative deflection, and that this negative deflection is deep, so taller or deeper than a couple of the small boxes, and it's also fairly broad. So we can be confident that these are Q waves in these leads and pathological Q waves. The leads in which we can see ST elevation, so V2, V3, V4, these cover the anterior wall of the heart, so the region of the heart affected by this STEMI or ischemia is the anterior wall. And we know the anterior wall of the heart is supplied by the left anterior descending artery, so we can be fairly confident that this ECG represents a complete occlusion of the LAD. So going back to our patient pathway, the patient's wife has called an ambulance, and in reality, looking at this ECG and the fact that Q waves have had time to develop, we could hypothesize that actually this ambulance isn't called until several hours after the initial event has occurred. Paramedics have performed observations and an ECG, and that ECG has shown significant ST elevation in more than 2 anatomically contiguous leads, so leads that refer to the same anatomical region or arterial supply. The paramedics will therefore immediately refer this patient to a centre that performs primary percutaneous coronary intervention. And hopefully that patient will be accepted by that centre and be transferred straight there. Until a coronary angiogram is performed, and shows that we have a complete occlusion of an artery, we wouldn't say that this is a definite diagnosis. There could be other things going on, but definitely top of our differentials at this point would be that this is a anterior STEMI with a complete occlusion of the left anterior descending artery. So let's talk briefly about coronary angiograms so you have a basic understanding of what they are doing. So I'm going to start by just removing the rib cage so we can see what's going on with our arterial and venous systems underneath. And let's get rid of the veins as well and concentrate just on our arterial system. So with a coronary angiogram, we would aim to gain access via the right radial artery, although sometimes we do go via the femoral artery, and a slim catheter is fed up the right radial artery, round and down to the point of around about the aortic valve. That catheter will then be engaged with the beginning of the left main stem, and contrast dye injected in, which allows us to take a picture of the left system of the coronary arteries. The catheter is then disengaged from the left main stem and engaged with the beginning of the right coronary artery. Again, contrast dye is injected, allowing for X-ray images to be taken showing the right coronary artery. In our case, taking into account the history and the ECG, I would expect to see a occlusion of the proximal LAD as shown here. Let's talk a bit about reperfusion or revascularization therapy for a ST elevation myocardial infarction. So a MI where we believe there is a complete occlusion of a coronary artery and where we want to get blood flow back down the artery as soon as possible. Primary percutaneous coronary intervention, PPCI, is going to be the first line choice of revascularization in pretty much everywhere that you will work in the UK, and certainly within the Hull York region in which you are studying. And what this basically means is emergency coronary angiogram and stent placement. The primary part referring to the emergency nature of this, so this occurs immediately without waiting for things such as bloods. So a PPCI centre, in York we are currently not one, Leeds and Hull are both primary PCI centres. And all that really means is that coronary angiogram and stent placement can occur 24 hours a day, 7 days a week when required. So these are just large centres that have the resources to be able to run that 24-hour service. We would be aiming for a timing in the region of from when that patient gets in the door of the hospital to have a balloon opening up that artery within under 30 minutes. Obviously, if there's another patient already on the table, it could take a little bit longer and they will accept up to around 120 minutes. If it was impossible for whatever reason to achieve those sort of timings to getting revascularization, then you might be thinking about another option rather than primary PCI. One of the other things that is a prerequisite for primary PCI is that the patient needs to be able to lay flat for the procedure. An average procedure might take around 45 minutes, but if complicated, they can take more into the region of hours, and the patient needs to be able to lie flat on the table for that time. Like any procedure, PPCI is not risk-free. There's approximately about a 1 to 2 in 1,000 risk of major complications, and some of those complications could be heart attack, stroke, damage to major blood vessels, and worst case scenario, death. So consenting these patients for the procedure wherever possible is really important, but obviously we wouldn't be recommending that procedure if we didn't think that the benefits outweighed any of those risks. Your learning outcomes still refer to thrombolysis for STEMI treatment. Now, this is still very rarely used, but it's fairly out of date now. Normally, people would have primary PCI for STEMIs. So thrombolysis or fibrinolytic therapy, it would be used as a second line choice. The times that I have used this or seen it used has been when we felt that the patient was so unwell that they wouldn't be able to lie flat on a angiogram table. So these would be patients that were presenting with acute pulmonary edema alongside those STEMIs. It is also, I believe, still used in regions without access to primary PCI. So this might be somewhere like the small islands off Scotland. Even there, I think most centres would try to helicopter patients off an island to get them to a major centre. But as I say, if your timing wasn't going to be good enough to get revascularization by getting that patient to a primary PCI centre, then thrombolysis would be your next best option. And basically this involves giving a large dose of a fibrinolytic therapy to the patient. It's obviously a systemic treatment rather than with an angiogram where you're just treating that local problem within the coronary artery. So the whole body will be affected by that systemic treatment of fibrinolytic therapy. And so there is obviously a risk of major hemorrhage, and that is probably about a 1 to 2 in 100 risk of hemorrhagic stroke or major hemorrhage. There is also a higher 30-day mortality and a higher 1-year mortality with thrombolysis. So the definite preference these days is for primary PCI as the treatment for a STEMI. The take-home point really is that time is muscle. So every minute that goes by that artery remains completely occluded, heart muscle cells will be dying and those will never regain function. You'll hear the stroke physicians say time is brain in the context of strokes, but definitely time is muscle here. So we're trying to revascularize that artery, get blood flow back to that area of heart muscle as soon as we possibly can, and with the least risk to the patient as possible. In this patient, a occlusion of the proximal LAD was found. These are just a few more moving images of coronary angiograms just for interest's sake. So here you can see a occlusion or a complete occlusion of the circumflex artery. And you can see here where a wire has been threaded down that occluded artery, and you can see the area where a stent is to be inflated. So on the left here, the before image of where that circumflex artery is completely occluded in a proximal region. And this is the after shot after a stent has been deployed, and you can hopefully appreciate that there's good blood flow back down that artery. And we've talked already a little bit about anatomical variance, and we said that 80% of people have a posterior descending artery that comes off the right coronary artery, in comparison to approximately around 20% who might have a posterior descending artery that comes off their circumflex. This is a particularly interesting case, but also highlights that there are more anatomical variances possible. So here you can see that you've got a catheter into the left system, so around about the left main stem, and there's very little, there's a small branch you can see, but apart from that it looks like the entire system is completely occluded. And this is actually a case of someone who had a aberrant circumflex artery that actually came off the right hand side alongside the right coronary artery. And this patient unfortunately had a complete occlusion of their LAD, so that only artery they had on that left side. And again, here you can see the thin whisper wire being threaded down that occluded artery, and on the right hand side the area where there is to be a balloon and then a stent inserted. And on the right here, the end result with excellent blood flow back down that occluded LAD. So I've already said time is muscle, and that is because dead heart cells are not going to regenerate, and dead heart cells are also not going to perform the pumping ability that we want from the heart. So all of these patients who have a myocardial infarction, particularly important in the context of a STEMI, a complete occlusion, these patients will have an echocardiogram. So don't worry too much about interpreting echocardiograms. No one at your stage is going to expect you to do this, but for interest's sake, here are some echo images. On the right hand side of the screen, I have drawn you a little diagram so that you can orientate what you're looking at. It really is as if you're looking at the heart in cross section upside down. I hope you can appreciate with this first video that the left ventricle, that muscle wall is thickening and contracting, and you can believe that that would be producing a good pumping ability. Contrast that with the second video where that left ventricle looks like it's barely moving at all and the muscle really isn't thickening, contracting. And this would be someone that had severe left ventricular failure, so the beginnings of heart failure. And this is the real worry with people who are not revascularized quickly when they occlude their left anterior descending artery, so that the artery that supplies that left ventricle and therefore the pumping ability of the heart. The other thing I really wanted to highlight to you in terms of this particular case is the patient's very strong family history, but then also thinking about the generations going forward. So we can't go back in time and stop his grandfather, his father, his aunt, or even this patient himself having that cardiac event. But we can think about looking into the future generations, so his daughters, his son, his grandchildren, and thinking about reducing their risk of having similar events at a similar age. In the last few years, a lot of research has been done into familial hypercholesterolemia, And we now know that 1 in 5 heart attacks at this sort of age, or certainly in those under 45, are due to familial hypercholesterolemia. To diagnose FH, we first look for a family history, like this gentleman has, of lots of cardiac events within that family at an early age. And then the case that we're looking at, we will test that patient's cholesterol, and we are looking for particularly high cholesterol levels, and we can look at different components of the cholesterol, particularly the LDL. If the patient both has that family history, especially if they've had a primary event themselves and they've got those particularly raised cholesterol levels, we can diagnose this as familial hypercholesterolemia. Once we've identified these sorts of patients, these days they will then go into a precision screening program to look at firstly whether they have FH, and then to be looking at other members within the family. In York, this service has been running as a dedicated service for the last couple of years, and I hope that in other centres or regions that you work at, similar services are now starting to become present. And it is really important to ascertain these patients and their families, because FH is manageable and we can significantly lower the risk of cardiac events in the future generations of these families. But unfortunately, FH still remains hugely undiagnosed in worldwide and in the UK. So I think current estimates still are that around 90% of these cases are undiagnosed. When looking at genetic disorders, FH is the genetic disorder that kills the most individuals worldwide, and also when compared to other genetic disorders, it is the most commonly found one in children. There are lots of excellent resources regarding FH at the FH Foundation, so it's really worth having a quick look through their website and what resources and educational materials they provide. But I'm going to leave it there for now, and let's move on to thinking about the second case you were presented with. Now, I imagine you probably found this case more challenging to think about, and that certainly was the intention. This case was really put in there just to encourage you within your groups to really have a good discussion about different differentials that could be there, and think about the processes that go on behind cardiac and other types of chest pain that patients might present with. So we have a 61-year-old man who is complaining of some central chest pain. But the background to this story is that this is a patient who's presented to the hospital with severe necrosing pancreatitis, to a level that this patient has had a intensive care admission. He is known to have sepsis and has been found to have a E. coli bacteremia, and he remains in hospital very unwell, although now off ICU. And back on the ward, he is complaining of some chest pain, and this pain is central, but it's sharp, and it's occurring on deep inspiration, but also he notes that it can come on when he's moving position in the bed. He rates it a 6 out of 10, and it's associated with some sharp thoracic back pain. In terms of his family history, he tells you that his brother died suddenly at the age of 50, and he thinks that this was a cardiac arrest, although he's not sure of the exact cause of that. Apart from that, he doesn't recall anybody in the family who's had any ischemic heart disease, so angina or myocardial infarctions. He was taking no medication before he was admitted to hospital. He's a non-smoker who, prior to admission, was fit and well for age, although he does tell you that he used to drink too much alcohol. He was independent prior to admission, lived alone, and has no children. Overall, he feels he's been fairly low in mood since he's been in hospital, especially as it has been such a prolonged stay. But he also tells you that he's worried about the pain and doesn't feel that anyone's getting on top of it or taking it seriously. So at this point, we'd ask you to start thinking about your clinical reasoning and your differentials and what might possibly be going on here. Key things that I would pull out of this history is firstly that this is a patient who's very unwell, septic, and continues to be unwell with his pancreatitis. The pain history given for his chest pain is not a classical presentation that we would see in association with a ischemic cardiac pain, but instead is more pleuritic in nature with that sharp pain on deep inspiration. The knowledge that his brother had a early death related to some form of cardiac arrest would certainly factor into our thinking with this patient. But at this point, we have no idea really if this had any relation to ischemic heart disease. But it would certainly make us, and we'll talk a little bit more going forward about this, but it would certainly make us more inclined to do something like an echo to make sure that there wasn't any obvious structural heart disease. The patient himself has no pre-existing conditions, including no pre-existing cardiac conditions and no major risk factors for ischemic heart disease. So at this point, I wanted to give you a quick aside about something called Occam's razor, which we often compare and contrast to something called Hickham's dictum. And if you haven't heard about this before, you're bound to at some point during your medical careers. So, Occam's razor tells us that the simplest explanation is the most likely explanation. And in medicine, we use this to suggest that if a patient has multiple symptoms or problems going on, then we are seeking a unifying diagnosis rather than diagnosing multiple unrelated diagnoses. There, however, are exceptions to every rule, and there will occasionally be patients who present with one or two unrelated pathologies at the same time. This is fairly rare, but Hickham's dictum encompasses this, saying a man can have as many diseases as he damn well pleases. So let's go back to the case and think about initial impressions and potential differential diagnoses. So far, the key points that I would pull out in this case is that the patient is firstly very unwell and septic, and secondary that what he's complaining of sounds very much like a pleuritic chest pain. With this in mind, let's talk about the top of our differential list. The first on my list at this point would be a pulmonary embolism. With Occam's razor in mind, we are trying to find a explanation for the patient's pain that will unify all the things that are going on. We know that a pulmonary embolism can present with pleuritic chest pain, and this patient has a number of risk factors for a PE. So he's septic, which is a prothrombotic state. He's had a prolonged inpatient stay with immobility, which will increase his risk of PE. And we also know that he has already had a thrombus associated with his pancreatitis. High up on my differential list would also be pneumonia. Again, pneumonia can give a pleuritic chest pain, and it's very common to see a pneumonia in association with a pancreatitis. And in addition, these patients' prolonged inpatient stay and immobility is likely to also have increased his risk of having a hospital-acquired pneumonia. We have not yet excluded any causes of his chest pain, however, so it's reasonable to still consider some less likely differentials. You might consider pericarditis, as the patient has mentioned that the pain is somewhat related to position. Whenever we're thinking about central chest pain, we would always consider whether there's a possibility that this could be ischemic heart disease or a myocardial infarction. And whenever anyone mentions a chest pain that is associated with a back pain, aortic dissection always pops into my mind, although I can't really find something that would unify this with pancreatitis. Moving on to our observation and examination. In terms of the observations, the main thing to jump out at you is that the patient's heart rate is very high and his respiratory rate is slightly raised, and those SATs are probably coming down to the lower edge of normal on air. The patient generally looks unwell and uncomfortable in the bed and looks clammy. His conjunctiva are pale, which can be associated with anemia, and this would certainly fit with someone who's had such a severe illness and has been in hospital for a long while. His heart sounds are normal and pulse regular, but he is markedly tachycardic. It's difficult to hear any additional abnormal sounds on auscultation of the chest, but it's obvious that the patient has limited inspiratory effort or is avoiding taking deep breaths. Abdominal examination fits with someone who is very unwell with severe pancreatitis, with 2 drains in situ, a NG feeding tube in situ and a urinary catheter in situ. His JVP is not raised and there is no sacral or pedal edema. So let's now look at this patient's ECG. Again, let's break this down logically in a nice structured modular order, starting with checking that it's an ECG of the right patient, the date and the time that the ECG was taken, and what the clinical symptoms are that go alongside that ECG. I can convincingly see a P wave consistently before every QRS complex. The rhythm is regular. As the rhythm is regular, we can use the 300 rule to calculate rate, and there are approximately 2 big boxes in between our R waves. 300 divided by 2 gives us a fast approximate rate of 150 beats per minute. Our complexes are predominantly positive in leads 1, but also in leads 2 and leads AVF. So this is a normal access ECG. The QRS complex is narrow. There is no obvious ST elevation or ST depression. There is no T-wave inversion. And there are no pathological Q waves. So in conclusion, I would simply call this ECG a sinus tachycardia. With this additional information coming from our examination of the patient and our ECG showing a sinus tachycardia, we would now think again what our impressions were and why. Starting with the top differentials, I would still have a pulmonary embolism at the top of my differential list at this point. Again, this would be because the patient has a pleuritic chest pain, which fits with a PE. He has a number of risk factors for PE, and a sinus tachycardia on an ECG would fit with a PE. Pneumonia would also remain at the top of my differentials. Again, a pneumonia can give a pleuritic chest pain. The patient has a number of risk factors for a pneumonia, and once again, a sinus tachycardia would fit with a pneumonia or sepsis. However, without having done further investigations, it's still reasonable to keep a number of other differentials on our list of things to consider. Let's now add in consideration of some laboratory or blood results. So the patient has had a troponin taken. Now it's worth noting at this point that some of us might not have advised on the patient having a troponin, but we don't always get that choice. Sometimes it's already been done. So this patient had a troponin and the initial result was raised at 42, and a repeat troponin was performed 2 hours later, and this was not only significantly raised but has also significantly increased. The patient's inflammatory markers, so white cell count, neutrophils, CRP, are all markedly raised. The patient's hemoglobin is stable but low at 80, and the patient has had a D-dimer taken, which has come back negative. So again, let's factor this new information into our impressions. So we now know the patient is very unwell and septic. He has pleuritic chest pain. He looks unwell and has lots of different things going on and has a poor inspiratory effort. He has a sinus tachycardia running around 135 beats per minute. He has a negative D-dimer but a positive troponin. His inflammatory markers are very high and his hemoglobin is stable but low. So let's have another look at the top of our differential list. And you will notice that I've now taken pulmonary embolism off this list of mine because the patient's D-dimer is negative, which almost completely excludes the chance of there being a PE. Pneumonia, however, would remain high up on my differential list. This is for the reasons previously outlined, and nothing that we have found excludes this as a diagnosis. The fact that this patient has had a troponin done and this is raised now means that we do need to consider more seriously whether this is a myocardial infarction. But given everything else that is going on, in terms of my differentials, I would be thinking that this is far more likely to be a type 2 myocardial infarction. This is because we already know that the patient has sepsis and pancreatitis and is very unwell, and he may possibly have a pneumonia on top of this. So these are things that are going to mean that the patient's metabolic rate and hemodynamics are already under strain, which means that he will likely be perfusing his coronary arteries poorly. He is also tachycardic. This may be secondary to his sepsis, but our coronary arteries fill during diastole, so the faster the heart rate is, the less time there is in diastole and the poorer those coronary arteries are filling. The patient is also anemic, and we've talked during our webinars about oxygen extraction rate, so the myocardium requires 70% of the oxygen delivered. And so if we have less red blood cells and they're less oxygen carrying capacity, this also means that we're going to have less oxygen delivered to that myocardium. In addition, when we look at the ECG, although we can see a sinus tachycardia, there is no definitive ischemia on that ECG to suggest that maybe a primary cardiac event has occurred. But again, we would still have some less likely differentials in mind that we might want to exclude. In terms of investigations, the first thing I would want to request for this patient would be an echocardiogram. Firstly, this would be to look at whether there were any regional wall motion abnormalities, so a region of the wall that was moving abnormally that could indicate that a primary myocardial infarction had occurred. So we were seeing an abnormal region of movement in the area of one coronary artery. In this patient as well, I would also be keen for an echocardiogram, given the fact that the patient has described his brother having an early death, possibly related to a cardiac arrest. So it would be good to reassure that there was no underlying functional abnormality in this chap's heart. I think in this case it would also be perfectly reasonable to consider whether we wanted to perform a CT of the thorax. This could indicate a number of things, including pneumonia. We can sometimes see a PE even if it's not a dedicated CTPA scan, and this would also exclude anything like an aortic dissection. In terms of management, for this patient, I would be aiming to treat the underlying sepsis and pathology, so to improve the patient generally and hemodynamically. We want to improve that tachycardia, which antibiotics and possibly IV fluids could help with, and this would improve his coronary artery filling. I would also consider optimizing the patient's hemoglobin, so improving the amount of oxygen being carried to the myocardium. It would be worth considering whether this patient has a pneumonia and speaking to microbiology about whether his current antibiotics, which are aimed more at treating his E. coli bacteremia related to his pancreatitis, whether these antibiotics adequately covered for pneumonia. And I would also want to ensure that the patient had adequate analgesia. Firstly, simply because this is humane, we shouldn't be leaving people in hospital beds in pain, but also this does serve a purpose in terms of it would improve the patient's respiratory effort and the patient's ability to cough, and this is going to help clear and expectorate any sputum, particularly infected sputum that is there, and would reduce the chance of pneumonia. this final slide just shows you that this isn't a random case made up to make you guys sweat and find a difficult case. This is in reality the sort of patient that I will see at least once a week in terms of referrals to cardiology. Now, firstly, be reassured that this patient was referred into cardiology, which means that the home team felt that they needed a specialist view on what was going on. So you are absolutely not expected at third year for your first case to have found this easy. It was simply there for discussion. But you can see my plan written at the time when I saw this patient. And I think, hopefully, this is a reasonable approach to the management of a patient like this, who probably simply had a troponin rise in response to sepsis and a number of other things going on, rather than there being a primary coronary artery event or a primary myocardial infarction. So I put this case in just as a stark contrast to the first case that we've looked at, where the patient had a very classic ischemic heart disease type cardiac pain, in comparison to this, in which there are lots of other things going on and the pain is far less typical and isn't something that needs aggressively treated as a primary myocardial infarction.